Session. Good morning, everyone. I'm your host, Raj Bajaj. Welcome you all to AIOS 2021 virtual conference. I'll welcoming Dr. Mohit Dogra from Chandigarh. Welcome, sir. Welcoming all speakers. Our first speaker is Dr. Jagat Ram. I'll request you to please unmute yourself, doctor.
Just prior to that, Mr. Raj, I'd just like to share a couple of slides, and then if I can go to Dr. Jagat, if it's fine.
Yes, sir. Sure.
Thank you. Appreciate that.
Thank you, sir.
Raman sir is in the wet lab.
यार तूने तो पहली बार में ढूंढ लिया मुझे. That's not fair. This is my kopcha.
This is your quiet place, sir.
My favorite place.
I think our chief instructor is gone. Dr. Mohit somehow logged out. Dr. Mohit is just joining again, sir. He'll be here in a minute or so.
So what happened? He got logged out by mistake?
Yeah, something. I think he was trying to share his screen and somehow logged out.
All right.
Yeah, I think sir is here now. So you need to unmute yourself, please, Dr. Mohit.
Apologies. I just went to share my screen and somehow Zoom just locked me out. I'm just going to quickly get down to it. And this is basically, is my screen visible now?
Yes, sir.
Yeah, okay. So again, welcome everyone to this, what I truly believe is a one-of-a-kind, interesting video-based, instruction course. And it's titled aptly, I believe, Surgery in Uveitis, a video-based series on the role of surgery in uveitis. Before I begin, I'd like to thank the entire selection committee of the AIOC for accepting this, and to all of my revered teachers and my colleague Simar for agreeing to be a part of this. This did not take too much on my part to convince anybody. It's a potpourri of different things. Before we get on straight to it, I'm just going to have one slide on what I believe we would be covering over the next hour and a half through the medium of this instruction course. So we all know uveitis can cause a lot of ocular morbidity, not only because of the underlying disease, but also because of its complications that it tends to bring along with it because of the disease and of the treatment. So this video-based IC highlights to most likely give us treatment algorithms to manage some of these patients, particularly the two most important complications, the two most common complications, starting with uveitic cataract and uveitic glaucoma. Then we get on to some of the, if I can say, lesser common, but if for want of a better word, more dangerous complications. With managing hypotony is not an easy task. And Dr. Raman will help us navigate through that treacherous trail with not only imaging-based clues, but also intraoperative videos, which I'm pretty sure will help all of us. Simar is going to bring in the vitrectomy, the posterior segment angle to it. Will talk to us about therapeutic vitrectomy, which is over the last half a decade now caught on quite a bit in uveitis. When for a long time it was thought that if in a hot eye or a uveitic eye you do any kind of vitreous surgery, the eye is going to sink. Simmer, I think, is going to tell us stuff to the contrary. And depending on how much time we have, I'm going to cover some basics of targeted biopsy, which is going to include extraocular, which could be systemic extraocular and intraocular biopsy in select niche patients of infective or neoplastic uveitis. And with this, before I hand it over to my esteemed teacher, Professor Jagatram sir, this is just a quick brief layout and the flow of how our instruction course should work. We're going to begin with the Professor Jagatram sir with uveitic cataract, followed by Pandav sir. He's going to talk to us on uveitic glaucoma. As I said already, Professor Raman's going to talk to us about managing uveitic hypotony. Simmer then talks about therapeutic vitrectomy, and I would like to share a few cases of targeted biopsy in uveitis. So without wasting any more time, I would request Professor Jagatram sir to share his screen and guide us through his wonderful video showing management of uveitic cataract. Professor Jagatram sir, please.
Okay, thank you very much, Dr. Mohit. It is nice to be in the team where we have Professor Pandav, Professor Ramandeep Singh, Dr. Simar Rajan, and Dr. Mohit Dogra. I will whether my screen is shared or not shared.
Not shared yet, sir.
Yeah, now
Yes, sir.
See it.
It absolutely, sir.
Okay. So I will be speaking on uveitic cataract, and this is a video-based presentation. And as you know, uveitic cataract is a common complication of uveitis. What is important is diagnosis of uveitis, pre-existing structural damage, and then the management, perioperative management, and then the surgical technique. And there is also important. It is also important to manage the post-operative complications. In the pre-operative evaluation, it is most important to establish the specific diagnosis, and then once any patient of uveitis develop cataract, it is important to control inflammation, and I should be quiet at least for 3 months. And then it is important to assess visual potential. In the pre-operative consideration, most important remains control of inflammation, and then we also think that which type of IOL we should implant. And as Dr. Mohit said, that it is important that how we manage cyclitic membrane, and whether to give perioperative steroid or not. Then in the operative period, a most important issue remains dilatation of the pupil, and then it is extremely important that we should implant the IOL in the capsular bag. And postoperatively, we must monitor patient for postoperative complication, whether it is a intraocular pressure, inflammation, or cystoid macular edema. In the surgical challenges, small pupil remains a challenge. We do, and there may be a lot of posterior synecholysis is done. Then we use several type of hooks and rings, such as Malaysian ring, or even some people do stretching, but it is better to either put ring or apply the hooks. Operatively, IOL implantation in the bag is utmost important, and whether to implant intravitreal dexamethasone or not, that is also one of the issue. This is one of the patient, 45-year-old patient with recent recurrent anterior uveitis, where we have done ND-YAG laser synecholysis. So this is one of the options for dilatation of pupil, and ultimately in this case, cataract surgery with IOL implantation was done. And this is our video, that how we place here we have done injection of DEX implant into vitreous cavity, and this is how we do synecholysis. This people is too small. This is just first we attempted synecholysis, and then this is the Malaysian ring, implantation of Malaysian ring, so that we can achieve adequate dilatation of the pupil. And most of the time, whether you put a Malaysian ring or Bhattacharjee ring, we can achieve adequate dilatation of the pupil. Then surgery may not be difficult. Most of the time, it may be soft cataract, as in this case. And you remove the nucleus, and you remove the cortex, and there should be no cortex left in the capsular bag. After that, you implant the IOL. It is important to implant the IOL into capsular bag. Here it is a 3-piece hydrophobic acrylic IOL, but nowadays, or most of the time, we may even put single piece IOL. Ultimately, it does not make a difference whether you put 3-piece IOL or single piece IOL once it is in the capsular bag. And then this is removal of the viscoelastic from the anterior chamber and closure of the section by hydration. And this is just an operative picture, and we go to the. This is the next video where we have done at least 5 of the procedure. This is a 25-year-old woman. Here we injected a Judex. It is injected 3.5 to 4 millimeter from the limbus. And here, because this marking you can see, because here we will be implanting the toric IOL. We have used Callisto. Here we did synecholysis. This is a different type of ring, which is known as eye ring. So this eye ring is inserted, and we could achieve very nice dilatation of the pupil. And then this is after Rex's hydrodissection, and it is a soft cataract. Patient is young patient. Then removal of the nucleus and cortex from the capsular bag. And whatever rest of the cortical cataract, that is removed from the capsular bag. And this is almost, we have removed the cortex from the capsular bag. This is after complete removal of the cortex. Then it is intraoperative aura, that how much IOL power we have to implant. This is in addition to IOL, the biometry which we do. And here we can align at the accurate place this placement of the IOL. And then we remove this eye ring. And then we remove the viscoelastic substance, and even from behind the IOL we remove. And then it was seen whether whatever our implantation was done. So here it shows that no rotation required of the IOL. This is the post-operative picture. And these are some of the study showing that intravitreal dexamethasone implant is required in several of the patients where there is a chronic uveitis. And these are the cataract patient. They improve their vision, and there may be some of the post-operative complications such as CME, PCO, and glaucoma, which we have to monitor in the post-operative period. Risk factor for IOL intolerance is JIA, pars planitis, chronic diseases resistant to remission, best outcome is achieved in Fuchs heterochromic uveitis, which even we are not discussing. And our studies have shown that we achieve excellent outcome in these cases. Whereas there are several factors limiting the visual outcome, that is glaucoma, hypotony, pupillary membranes, and cystoid macular edema. We have to monitor the patient for these complications in the post-operative period. So in short, we can say phacoemulsification, within the bag implantation of IOL is the procedure of choice for a patient with well-controlled uveitis. Pre-operative and post-operative control of inflammation is extremely crucial. Meticulous surgical technique is utmost importance. I believe that we have to follow up these patients for long time, because there may be recurrence or there may be several of the post-operative issues. Thank you very much.
Thank you, sir. Thank you, sir, for that. As always, sir, it's a pleasure to listen to you on this topic. Your videos and, sir, the ease with which you make all of these challenging surgeries appear not that challenging, sir. I think it's just testament to your superb surgical skills, sir. Thank you so much, sir, for that presentation, sir. Thank you.
Thank you, Dr. Mohit. If there is any question, no issue, I will be happy to reply.
Sir, I was thinking that we will have Dr. Panda's talk, sir, and then we will have questions for you and sir together, if it's okay with you, sir.
Okay, it is fine. No issue. I am here.
Sir. Thank you, sir. Thank you. And without further ado, I would like to call and request Professor S.S. Pandav, sir, to enlighten us with his approach to managing uveitic glaucoma, which, if I dare say, is as challenging as managing uveitic cataract. Professor Pandav, sir, please.
Can you hear me?
Absolutely, sir. Absolutely.
Okay. So thank you, Mohit, for inclusion into this program. And as you said, glaucoma and uveitis is challenging, and it's not. It's also quite common, actually. If you look at prevalence in uveitis patients, almost 10 to 20% of uveitis patients, they would end up with high pressures at some point of a time or the other. And in chronic cases, chronic recurrent cases, this figure is actually quite high. It could go up to 50%. There are many challenges in the management. It's not only the inflammation that you have to control, but you also have to control the intraocular pressure, and also inflammation, as well as many of these patients would have other associated pathology. They may have cataract, they may have disorganized anterior segments, so it becomes quite challenging at times to deal with these cases. Now, IOP can be, have an acute rise, when there's acute uveitis, something like you see in HLA-B27, or more often you have a trabeculitis, which is very often associated with viral pathologies. Sometimes you don't know exact cause, like you have a Parsons-Schwarzman syndrome, and but more often it's the chronic uveitis which leads to a chronically elevated intraocular pressure, and very often this would be associated with structural changes at the angle in the form of synecdoche or anterior synecdoche or posterior peripheral anterior synecdoche or posterior synecdoche. And what complicates things is also that sometimes the therapy for the uveitis, which is required, also leads to high intraocular pressure. So you have to figure out what is the underlying mechanism in a given situation. And for that, a very careful clinical examination is very important. The goal of therapy is to control inflammation and also to control intraocular pressure to protect the optic nerve. Sometimes the IOP rise may be very acute, and this is going to subside with the control of inflammation. But if that lasts for too long, then by that time optic nerve may be damaged. So in certain situations, you might have to act quickly, even in the presence of inflammation. So most of the cases, they're controlled with medicines. And if we look at all our patients, about 2/3 of the patients, they would be well controlled with medicines, but there would be 1/3 to 1/4 of patients which are refractory to medical treatment, and they would need surgical intervention. Now, when you're doing medical therapy, it's important that we understand anti-glaucoma medicines, and we generally avoid giving prostaglandins and pilocarpine. That's the drugs which are prone to induce inflammation. Sometimes you have a picture like this when you have it, iris bombay as seen on this pictures up, and below is the OCT. In these situations, a laser iodotomy, can really, is required, and it can actually make all the difference, and you might be able to avoid surgery and control pressures with a simple iodotomy in these patients. But these patients would repeat repeated iodotomies because with the continued inflammation, the iodotomy tends to block. But in a situation where where the medical treatment has failed or is not working, then we need to do glaucoma surgery in these patients. And the important thing is that the eye should be quiet for 3 months before you do surgery, and there should not be any structural damage. If there's extensive structural damage, then the trabeculectomy may not be worthwhile. And this is a 57-year-old male who was well controlled. Anterior segment is fairly preserved. There are some synecdoche, but eye could not be controlled with maximum medical therapy. So we are doing a trabeculectomy here. Again, another important issue here is that you always consult the person who is treating uveitis, because before and after surgery, you might have to change the anti-inflammatory drugs. Sometimes you might have to give more in the perioperative period. Medical surgery is very important because these patients are already at a higher risk of failure. We always use mitomycin C. So these sponges were mitomycin sponges. They are kept there for about 2 minutes. And after you removing the sponges, you make sure that you thoroughly irrigate the area to get rid of the excess of the mitomycin C. Once that is done, I think the rest of the procedure is very much similar for any other glaucoma trabeculectomy. So you enter the anterior chamber, make a scleroscopy with a Kelly sponge, do an iodectomy. Again, you have to be careful, like maintain the chamber all the time. Don't let it collapse, because these inflamed eyes are there higher chances of having post-operative complications like hypertony and choroidal. So we try to keep the chamber formed as far as possible during surgery. And then, of course, you have to close the flap, use some releasable sutures. So they help you in the post-operative period if the pressure is not controlled. And once you are satisfied, you have a good closure, then conjunctiva and the Tennant's capsule, they are closed together in a way that you get a tight, so there's no leakage in the post-operative period in the limbal area, and that end result is pretty good. And post-operatively, of course, you have to be, these patients may need intensive steroid therapy. So trabeculectomy, if you look at the results, TRAV in a properly selected case of uveitis can give you good results, and this study indicates that at least 50% of them would be have a good IOP control in 3 to 5 years time. So, but sometimes the trabeculectomy is not really a good option. And like in this case, you can see there's a scleritis which is healed, 50 years old female, and there's a ciliary staphylomas. So there's no way you can do a trabeculectomy in this patient. So here, what you can do is we can still put a tube. And usually what happens is that if you go beyond the area which is staphylomatous, and you'll find it, healthy sclera. So because these devices are sutured posteriorly, so you can find in healthy sclera posteriorly and put the implant in that area, and that will give you good area to work with. And once you have done the implant, you basically have to put the tube. Now, important thing is that because this area is not very healthy, so while you're putting the tube, again, you have to be very careful, because this tissue doesn't have much strength here, and if you do multiple entries, then this is not going to hold. And it's again very important to protect this area by using a scleral patch graft from a donor sclera from an eye bank. And once this is established, one can expect a good result. So in the end, you close conjunctiva and Tennant's capsule over it so that you give it a nice closure. This is another patient with a GIA. GIA is actually very difficult. This patient has already undergone through multiple surgeries, including trabeculectomies and IOL. And similarly here, again, we are using an implant. So I use an ADI implant here, which is a non-valve device. So In these patients, you can use any device, valved or non-valved, and both will work fine. The valve devices, they are better in the sense that the incidence of postoperative hypotony is less. So GIA is glaucoma is a common cause of loss of vision in GIA patients, and because there's extensive structural damage in these patients, and this is an ongoing process. Another important thing to remember for these patients is that the ciliary body is also malfunctioning in these patients because of chronic inflammation, and so they have a tendency to go into hypotony as well. So we have to keep that in mind also when we are doing surgery for these patients. And this is a non-valve device, so important thing is to suture the tube so that there's no hypotony. And also, if there's no place in the anterior chamber, you have to put this tube in the sulcus sometime. So if you look at the outcome of these drone devices, both valved and non-valved, they actually fare pretty well in these. And the long-term results are is quite good with both AMD as well as AGV. You can see there's a persistent control of IOP is there. This is our own experience of doing close to 90 eyes where we did trabeclectomy, AGV, and ADI in patients who had uveitis, and these are the all varied diagnosis entities were there. Most of them were chronic uveitis, 2/3 of them, and 1/3 of them roughly were acute uveitis. And you can see all the trabeclectomy, AGV, and ADI, they all give you good results over a period of 5 years. ADI seems to have a little advantage in terms of giving somewhat lower IOP as compared to other two. And also there's a significant reduction in anti-glaucoma medicine in all these situations. To summarize, the glaucoma in eyes with uveitis is very challenging, and surgery is often required when medical therapy fails. Trabeclectomy or GDD are all viable options, but the patient selection has to be good. And if you choose your patients, properly, all these three can help you control intraocular pressure. Trabeclectomy has a little higher incidence of failures as well as of complications. So there were tubes are more often preferred for these cases. Thank you again. Thank you very much, Mohit, for including into the program.
Thank you. Thank you, sir. Thank you again, sir, for that excellent presentation, sir. Very succinct, and I think covered all aspects, sir. So thank you so much for sharing your experience. And now quickly, sir, because I would want to stick to time. I think we're just bang on time, sir. If I'm going to pose a few questions to Professor Jagatram and Professor Pandav, sir, regarding both of your talks. I wanted to take, sir, your and sir's questions together because some of them might be linked, and I know that, sir, you also do a lot of cataracts, so we could have your opinion on that also. My first question, sir, would be to Professor Jagatram, sir. So in your personal opinion, sir, in uveitic patients with either pediatric uveitis or adult uveitis, if affordability is not a problem, sir, for managing pupillary meiosis, for managing extensive posterior synechia, sir, would you prefer using hooks, or would you recommend or prefer any of these other devices like the ones that you showed, sir, the Malyogen ring or the eye ring? Do you think it matters, sir? There is any difference if money is not a consideration the patient is affording, sir?
Yeah, definitely. I think you are very right. If affordability is not an issue, then we may not like to stress the people. Then, and ideally, I will like to implant the ring, whether it is a Malyogen ring or Bhattacharjy's ring or any of the eye ring, because that is much more smooth delivery and removal. And whereas I think hooks, that is my second choice. Okay, you place hook, that is also equally effective in most of the cases. So first choice remains ring, and second remains hooks, and third, of course, when nothing is there, stretching is one of the options.
Absolutely, sir. We have seen you do that so many times during our training days with you, sir, stretching hooks with using two bimanually. Absolutely, sir. Thank you. Sir, I also had another question, sir, to you, which was regarding what would be your indication, sir, or at what age, especially in pediatric uveitis with complicated cataract, would you combine cataract surgery with a primary posterior capsulotomy and anterior vitrectomy, sir, in pediatric cataract, uveitic cataract, sir?
Definitely, we had one child recently that was 1 year old, and it was a idiopathic uveitis. and I have documented that. And we implanted IOL in the bag and did simultaneously we did the primary posterior capsulotomy. Otherwise, after few days again we have to go to theater and we have to make posterior capsulotomy. So it is all right. You have to place IOL in the bag, not in the sulcus, and then perform the primary posterior capsulotomy. That is my view on it.
So there are the chances of PCR higher in uveitis patients as compared to the other, especially in children.
Yeah, definitely. I think it is very tricky because Dr. Raman, he also deal with several of these children when there is any post-operative complications such as JIA and other in the younger age group. It is much more difficult to treat them and even to manage their complication. Cyclitic membrane and some of the other issues of hypotony, even high intraocular pressure, that remain challenge, particularly in the pediatric age group.
Sir, I just wanted to ask you, in case you have a PCR on table where you think the IOL can't be put in the bag, so in that situation, would you like to put in the sulcus, or you leave it, kind of aphakic and deal with it later? Or
We try our best not to have PCR, but anyway, if it happens and if there is a adequate support, we will like to place the IOL in the capsular bag. But if support is inadequate, we place a 3-piece IOL in the sulcus, or we may do optic capture. But never put, I think, single piece IOL in the sulcus.
Thank you, sir. Thank you, sir. Thank you for those extremely important clinical tips, sir, which I think everybody will benefit from. So I have two quick questions, Pandav, sir, to you, sir. Now, sir, just one. The first is regarding so the Iris Bombay that you briefly touched upon, sir, and the fact that in primary angle closure disease, one PI generally tends to work, but in secondary angle closures like uveitic Iris Bombays, so would you recommend at the outset, sir, doing multiple, at least 2 or 3 peripheral either laser iridotomies which are larger, or would you still recommend doing one first, and if it closes, then going for more than one in the second sitting, sir?
I think it depends. When you do first laser iridotomy, you see the AC gets flattened immediately. So, but it may not happen, uniformly, and there might still be pockets which are not drained because of that eccentric synecdoche. So, if you have done laser iridotomy and you say that 1/2 or 1 quadrant of the iris AC has deepened, but the remaining is not deepening, then you have to do multiple in the first sitting itself. The only issue is that because there's inflammation in the eye, and sometimes you don't want to use a lot of laser energy in one sitting. So if it is achieved easily, then you could do 2 or even 3 laser iridotomies in the one sitting itself. But that limits us, how much energy you want to put into the eye, because this is an inflamed eye. So if the one eye deepens the anterior chamber uniformly, then we will not go for the second or third eye, just enlarge that one and wait. If it's closer, then do another one. But we prepare that these eyes, this LI might close. And
Thank you, sir. Because I personally find that dilemma, so want to ask. And before we move on to Dr. Raman, sir, a quick question to you, and I will then come back after Raman sir's talk for a question, sir, because it will be linked to Raman sir's talk and you. So sir, in uveitic eyes, predominantly, I would say the adult uveitic eyes, sir, what would be your indication for combining cataract and GDD or cataract and or doing a phaco trap, sir? Would it be similar to what you would have in non-uveitic eyes, or is the or will the uveitis alter that decision, sir?
I think definitely, because if the eye is inflamed, the more surgery you do, the more difficult it will be to control the inflammation, and also post-operatively you will get more chances of your failure of your glaucoma surgery, and as well as complications of the cataract surgery. So as far as possible, we like to avoid, but there would be certain situations where uveitis, if it's fairly well healed, it's controlled, and you have cataract and glaucoma both, then one can go in for a combined surgery in that situation. So we do combine surgery in the eye, which is quite, and the recommendation is that let the eye be quiet before, for 3 months at least before you do any of these things. So combined surgery can be done in these patients when both the visual rehabilitation as well as IUP control both are required. And many of these patients, they would have synecdoche, they would have high IUP, and they will also have cataract. So in that situation, it does make sense to combine the surgery to give it quick rehabilitation as well as IUP control.
Thank you, sir. Thank you. Thank you for those quick
Thanks,
comments.
Mohit, for asking this question. I had that question in mind, and Dr. Pandav has asked that very aptly, actually. Thank you so much for asking.
Yes, sir. Thank you. So with that, sir, I would like to invite you, Professor Ramandeep, please to share your screen and to enlighten us on what I believe we're going to change tracks a bit. With from high IOP, we're going to go to hypotony. So, Dr. Raman, sir, please.
Yeah, Mohit, I'm going to start with play my video there, actually.
Thank you much, Dr. Mohit, for the invite in this IC. Hypotony, that is IOP less than 6 in uveitis, is one of the vision-threatening complications in any uveitic patient due to neglect or late referral. Normally, they are accompanied with cataract, mostly with the cataract. So these eyes are poor prognosis eyes, as seen in these ultrasound. These are pre-thysical eyes and short axial length, and they are left alone. Doing a cataract surgery in these eyes can be very, very devastating. So in eye which has hypotony, the GI and many other chronic uveitis may result in hypotony. Its incidence has been reported as high as 19% in GI, and in the latest MUST trial, this is something like in the whole, all the uveitic entities, something like 8%. So what is more important is to find out the cause of this hypotony, because acute hypotony will require taking care of the inflammation and cellular coronary detachment with the medically, and the chronic will require, apart from the medical, non-surgical treatment also. And it is where here the UBM will help, because UBM is the only tool which will tell us about the health of the ciliary body. Again, a retroiridal structure, so UBM will be able to pick up, and UBM will be able to show us whether a normal looking ciliary body is there or not. Here you can see a cyclitic membrane which is very thick over a normal looking or slightly blunted ciliary body, or a ciliary body which is the exact shape is not there, but there is no cyclitic membrane also, but you can see the ciliary body is blunted, and you can see these finger-like projections are lost in the scan, and you see a thin membrane there. So these are the chronic changes which are seen on the UBM in the hypotony to require a surgical management. And it is here the UBM, once it tells us that cyclitic membrane is there, as we know that this cyclitic membrane will be causing a traction and traction kind of detachment from the sclera, resulting in an increased uveoscleral outflow and thus hypotony. Or there will be a cyclitic membrane along with the ciliary body atrophy. The cyclitic membrane, if left for a long time over the ciliary body, will damage the permanently the ciliary epithelium in a pigmented and non-pigmented part. So removing it at the time when the ciliary body is healthy is important. So once the ciliary body atrophy has set in, the aqueous production cannot take place. You have to replace it with the agent in a desperate measure to save the eye going into thysis bulbi, like we use oil in these patients. So this is an example of a GI patient with cataract there, with the hypotony there, where we went ahead and with the help of a UBM, we could see a cyclitic membrane in this eye, and we went ahead to do a lensectomy and a cyclitic membrane removal. And we already knew that the patient had a healthy ciliary body in nearly 5 to 6 block and a ciliary body atrophy in the rest of the area. So you can 3-port Pascana vitrectomy approach is used. We were able to see the cannula inside through this lens, and iris hooks are used to exactly see the capsule and the lens and the iris, so that we don't cause iatrogenic injury to the iris and the the ciliary body and the pupillary structures. So a meticulous dissection is done with the help of a cutter and the suction. And again, I've told you why it is important, because we need to have a good view of the periphery, so that we are able to see the ciliary body clearly when we come to dissecting it. And once you've removed the lens capsule, the lens matter, and the peripheral vitreous, only then we will be able to prevent the recurrence of this membrane in this area. So with the help of a suction and of the cutter, I'm removing this lens matter, and the capsule is removed with the help of a forceps also, and the synechias are broken. So this removal of the capsule has to be very, very gentle, because pulling it with the with these zonules of a child can be very, very it can cause injury to the peripheral retina or the periphery there. So you have to use a cutter and the forceps both, and which will help to take care of the capsular remnants in the periphery. Again, we do a complete vitrectomy with the hyaluronic removal in these patients, because we do believe that if you have to give tamponade, the complete vitrectomy should have been done. And again, these uveitic eyes, it is important to remove as much as inflammation and debris possible from the eye. So we believe in doing a complete vitrectomy, not only the core, not the core vitrectomy in these patients. When the meticulous hyaluronic removal is done with the use of Canacot, and once you have removed the periphery, and then we'll be able to see the cyclitic membrane clearly, as we will just see in this patient. We can appreciate the blurred disc margins in this patient due to the hypotony, though we are not seeing any the folds in the retina, but the patient has this thing. The inferior peripheral findings are also there. They are known in the GI patients, and this is here. Apart from the inferior, now we see this cyclitic membrane, and this ciliary body is the healthy. Why I'm calling it healthy? Because I am seeing the ciliary body projections. Finger-like projection. I'm also seeing the brown color of the ciliary body, and it is between these two fingers I'm snipping with the horizontal scissors. You can choose vertical scissors or a horizontal scissors. Once you have snipped these meticulously, you be able to cut this tissue with the cutter. You have to take care that you don't injure the ciliary body, because it may cause the bleed there. Bleed there has to be taken care by increasing the bottle height. And don't pull the ciliary body, so that you don't cause iatrogenic detachment there. And this is important to do this surgery very, very slowly. And again, I'm using one hand to do depression and other hand to do take care of the cyclitic membrane, cutting with the scissors there. So now in the next step, now again, these fibrous remnants are now being removed with the help of a cutter, and we're using a low vacuum there and a moderate kind of a cutting there, and see the other area now. The other side, the membrane is more thicker, and the ciliary body fingers are blunted and it's white in color, showing that this is how the atrophy looks like clinically. Dissection here is more difficult, but again, you have to try to release as much as cyclic membrane is possible, because more is the healthy ciliary body, lesser is the need to use a tamponading agent like oil. So again, a meticulous dissection is very important. Again, this is a high magnification view in this eye. So you can do this procedure very meticulously with under the microscope illumination at high magnification. So once you have completed the vitrectomy, and then you give it tamponade or no tamponade, so the surgery is closed. I'll be sharing here our experience from 2009, where we have shown that in the eyes with the hypotony, it is better to put oil in these patients where the ciliary body atrophy is there. You can see these last 4 patients with the oil, their IOP is somehow staying up to like 12, more than 10, and we had a follow-up of 22 months. So what was lacking in that study was we tried to see that how much ciliary body is important for the working of the eye, for preventing the eye to go into hypotony. So we wanted to see our results in 21, but again, the number of eyes are very less, and we can only find the 3 eyes where we use silicone oil tamponade, and you will see that out of these 3 eyes, over 5 years follow-up, 2 eyes went on to develop glaucoma now and needed glaucoma drainage devices. But eventually, they are doing something like 636 and 66 in the other eye, and immunosuppression is also continued. It made us believe that probably the eyes with the complete ciliary body atrophy, not the incomplete ciliary body atrophy, will need oil. So now we believe that silicone oil tamponade is kept only for the eye with the hypotony and complete ciliary body atrophy seen on UBM and intraoperatively. Again, meticulous CM removal is possible in these patients, and it brings out good results. But again, the war has just begun, because you have to give immunosuppression to these patients for a long time. We have to keep under long follow-up, because we have to keep the remaining ciliary body healthy. Again, I did not touch upon the endoscopic guided removal that can also be done in these eyes. These are my references. Thank you for your patience here.
Thank you, sir. Thank you for that excellent talk. And as always, sir, charting out an algorithm for us and to tread on the path which is less trodden on by a lot of people. I'm going to quickly come to 2 questions, sir, and then come to Simar. And then if we should have some time at the end to go back for questions to everybody else, sir. So my question again to you would be, sir, so in what kind of pediatric uveitis would you not, and this is JIA or non-JIA associated, would you not want IOL, sir? In, let's say, if whether you're doing surgery or our anterior segment colleagues are doing surgery, sir.
The things, when we started in 2000 or 98, the GI used to be absolute contraindication for these patients. But over the time, the things improved and our immunosuppression, our management improved. So in 2020 and in this era, we are using, the IOL in GIs also. So to say that which are the eyes where I will not dread into the tract of putting an IOL is, I think these are the eyes with the hypotony there. So if you have a hypotony in these eyes, and you can find out a reason that this hypotony is due to the cyclitic membrane, or it is due to the ciliary body atrophy, I will not put an IOL in these eyes, because you cannot, because the number is so low. I think that if the 360-degree ciliary body atrophy is there, so you absolutely no IOL in these eyes. But if the cyclitic membrane is there and nearly about 2-3 clock hours of ciliary body is also good, I will suggest that put an IOL and then do a cyclitic membrane removal in the second surgery would be a good choice. But with the 360-degree ciliary body atrophy, no IOL. So that will be my take in all the eyes.
Great, sir. One more question, sir, that I would like to pose is, so for eyes with hypotony in which you've put in 5,000 centistroke oil, so pretty much the worst case scenario when the ciliary body is also atrophic, and we know that the eye will not be able to produce too much aqueous. Sir, any experience or any role you feel personally of silicone oil retention sutures, given that these patients are invariably have been made aphakic by us, and that long-term keratopathy and those issues might be an issue, or you think it's not required, sir?
Mohit, I think if you take care of your pupil very well, your iris will not be, the pupil will not be more than 3 or 4 millimeters. All right. So you have to really take care of pupil very well. And in these hypotony eyes, you don't have to make a PI also. So we don't make an inferior PI in these eyes. So I don't think if the pupil is not large, or you have iatrogenically, you're not touched it, or only in those cases you can plan a retention suture. Otherwise, they are not required. I have no personal experience with that. I have not used it till now.
Absolutely, sir. Thank you. So, Simar, if you were to start sharing your screen while I pose one question to Pandav sir and one to Jagatram sir, Pandav sir, there's one question in the chat box, and this is a bit of a continuation of what we discussed, sir. So in eyes with uveitic eyes with iris bombay, but with normal or low to normal IOP, would you still recommend laser peripheral iridotomy, sir?
Yes, I think that's a good question, because sometimes you do see iris bombay formation and the IOP is still normal. That could be because some angle is still functioning or the ciliary body is hypoperforming, but eventually the pressure is going to go up in these eyes. So other risk is that if you leave the iris bombay configuration that way, then there'll be peripheral anterior synechiae and permanent closure of the angle would happen. So I think anytime you see this kind of configuration, it's better to do a laser iridotomy and deepen the anterior chamber so that whatever angle is healthy remains, that opens up and the further synechiae formation doesn't happen. So I think even if the IOP is controlled at that point of time, laser iridotomy should be done.
Should be recommended. Absolutely, sir. Thank you. And one last question to Jagatram, sir, before we ask Simar to present his interesting talk on therapeutic vitrectomy in uveitis. Sir, this is regarding, again, a continuation of what Pandav sir asked, except that I'm going to ask that in the adults, sir. If during uveitic cataract surgery, let's say there was a complication, PC rent or a zonular dialysis, they can have loose zonules also, and a secondary IOL is planned either in the same sitting or a delayed sitting, sir. Would you recommend a scleral fixated IOL or anything, any difference, sir, that you would have as a choice for a secondary IOL in these eyes as opposed to non-uveitic eyes, sir?
Yeah, definitely. If there is a loss of sport in these, although we take full care, but if still there is a loss of the support during surgery due to posterior capsular rupture, then usually we may not like to do transscleral fixation at the same time because the eye may be very hypotonic and to pass the needle may be a little problem. Most of the time, not always, but most of the time we try to do it after 6 to 8 weeks. And personally, I like to implant transscleral fixation of IOL, and in some of the cases, we have also done sutureless scleral fixation of the haptic.
Absolutely, sir. Absolutely. Point taken, sir. Thank you.
I will like to comment on the presentation of Dr. Raman. I think those removal of this cyclitic membrane, very impressive. Always I like that video, that how carefully he removed the cyclitic membrane. And that is one. And another is Dr. Pandav, that image where he has that iris bombay, that is also outstanding. So I think this is what this was my comment.
Thank you, sir. Appreciate it, sir. Thank you. So again, in the interest of time, Simar, can we dive straight into your topic? The floor is all yours on therapeutic vitrectomy in uveitis.
Thank you, sir. I think there is some issue with my webcam, so that's not going to work. I have my photo out there. I'd like to thank AIOS for selecting our instruction course, Dr. Mohit for having me in it, and my teachers at the Advanced Eye Center, my mentors who are part of this course, Professor Jagatram, Professor Pandav, and Dr. Raman. So I'm going to be talking on therapeutic vitrectomy in uveitis. The first report of lensectomy vitrectomy for a complicated cataract or something that we just saw with Dr. Raman came out in 1978. So unlike surgeries in other surgeries in uveitis, like we just heard about cataract and glaucoma, a period of quiescence may not be required for vitrectomy, as control of inflammation is one of the objectives of doing a vitrectomy in a lot of these cases, and also reducing the requirement for immunosuppressive therapy. So in a large review that was conducted, published in 2018, they reported reduction in CME from 52% to 37% in eyes which underwent vitrectomy, and reduced use of corticosteroids from 48% to 12% post-operatively in after vitrectomy. So that is a major reduction in the requirement in the inflammation as well as the requirement of anti-inflammatory therapy. And micro-incision vitrectomy has also greatly enhanced the role of vitrectomy and has increased our confidence into what all indications we might go in. These are two important review articles published, one from the US group and one from our center at PGI and the RP center in AIMS, which overview the role of vitrectomy in uveitis, if one would want to go through it. So I would be concentrating more on the videos, as is the video-based course. And whenever we are doing vitrectomy in uveitis, it's going to, most of the cases, it's going to have a diagnostic as well as a therapeutic angle to it. I will be talking more on the therapeutic aspects of it. So there are 4 broad indications for which a therapeutic vitrectomy in uveitis might be needed. The most common of which will be endophthalmitis, which can be post-operative, endogenous, or traumatic. And then would be a media opacity like a complicated cataract, we just saw that video, vitreous membranes, or vitreous hemorrhage. Inflammation control is an upcoming indication and has become an important indication. Lens-induced uveitis, obviously, we used to do before also. Irwin gas syndrome and recalcitrant uveitis. And obviously, the structural sequelae of uveitis, something like epiretinal membranes, macular hole, retinal detachment, and a cyclitic membrane. We just saw very nice videos of that. I'll be just touching upon 1 or 2 cases in each of these scenarios to just show how what all is possible. Coming on to endophthalmitis. So this was a 52-year-old male, typical history, poor visual gain following cataract surgery 2 days ago, and pain, redness, photophobia. You can see the steamy eye, the corneal edema, the hypopyon, and also the fibrin in the anterior chamber, and echoes in the vitreous cavity. So we took this eye up for a primary vitrectomy, and a lot of these eyes, it's important to remember, since they are not operated recently, the large main ports need to be sutured before you start your infusion, because our infusion pressures of 30 or 35 will make these wounds to give away. And important to clear out the fibrin in the anterior chamber to clear your view, also to reduce some amount of inflammation. Here I am using a cutter to do the same, and also the fibrin membrane, as you can see, coming out from the angle. And then we go into the posterior segment. The posterior part is just to be done a core vitrectomy as much as you are comfortable doing, and as soon as you get a red glow and a view of the posterior pole, I think that's about it. Now there is now an upcoming role of a more complete vitrectomy to be done, and then the intravitreal antibiotics, and you can see the results can be very gratifying, and you can see the complete anterior chamber inflammation controlled and a fundus as if there was no endophthalmitis ever. So just another video to show another technique of the fibrin membrane removal in the anterior chamber in these eyes using a needle cystitome, just like we do for a capsulorhexis. And this sample then again can be sent for microbiological examination, and that helps in our diagnosis. Another case of a 45-year-old diabetic man who presented with decrease of vision for the last 1 month, had fever, dysuria, and uncontrolled blood sugars. You can see this endogenous endophthalmitis picture. Right eye, the coming out right at the posterior pole in the fovea, and the left eye along the inferotemporal arcade, and another lesion right here. And the OCT showing the rain cloud sign of that thing erupting from the choroid and into the retina and the vitreous. So urine culture was positive for Candida albicans, sensitive to the azole group and resistant to amphotericin. And the right eye was, both eyes were treated with intravitreal voriconazole and IV voriconazole. The right eye was responding well, the left eye not so much. So the left eye was taken up for vitrectomy. The other reason was this lesion being very close to the fovea. Scarring would have resulted in attraction on the fovea also. That was one of the concerns while deciding on a vitrectomy. After the course, the hilar detachment was kind of tricky. It was kind of stuck on over here. And then while detaching it over here, because the whole retinal involvement was there, there was a break also over this lesion. So the hilar was detached around that lesion all around, and then brought out and trimmed over the lesion. So since this retina was involved and the retina was already lifted, so that much part was cut out with the cutter. Of course, samples were sent from these lesions and closed so that they give the best yield. So to prevent that post-operative traction on the fovea, ILM was peeled from over the posterior pole after staining with BBG dye. And we could see that after peeling this ILM from over this lesion also, we could still get some more part of the lesion out with a soft tip cannula. And then a partial fluid air, full fluid air exchange, and SF6 tamponade was given due to the break along the inferotemporal arcade after doing a good laser around that lesion. So this is the SF6 going in, and also intravitreal voriconazole was repeated at the end. So this was post-operatively. This is a 10 days post-operatively. You can see this lesion has completely gone. The retina is attached, and even this lesion has started to scar with this. This is a scan passing vertically here, and somewhere around is the fovea, and we do not see any semblance of any traction for now, but we'll need a longer follow-up. The right eye had already scarred right at the fovea, so nothing extra could be done here. Coming to the second group of media opacities, I think this is a 7-month-old child. You can see the whitish reflex that the child came with. So we do see a lot of vitreous hemorrhage in these children less than 1 year of age. A lot of them vasculitic, come out positive for torch titers. Our direct correlation to the etiology is a little difficult to say. So you can see this hemorrhage, relatively easy surgery, but a media opacity in a 7-month-old child is very embryogenic and can't be left for long. And you can see this involved area right here with the vasculitis and the retinal pigmentation. Prophylactic scatter laser was done in that area to kind of prevent any further NVE forming and any further vitreous hemorrhage. A partial FAX, and since we were using 27 gauge, we could leave this sutureless, and this is another great advantage of the microincision vitreous surgery. Post-operatively, both eyes had a clear media at least, and CMV titers were positive for this patient. So coming to inflammation control, lens-induced uveitis, I'll be talking about a case of recalcitrant uveitis, a 40-year-old male with recurrent vitritis and vascular leakage, idiopathic. We never found the cause despite investigation. Whenever there was a reduction in the immunosuppression, the inflammation used to come back. So we decided to take him up for a diagnostic and therapeutic vitrectomy. So this is just initial sample was taken under air to get a good yield, and then after that triamcinolone was used to stain and identify that there is no posterior hyaloid left at the posterior pole, and then the peripheral vitrectomy was done. Nothing with depression, but just as much as was comfortable up till the equator, and that was about it. That concluded the case. And post-operatively, this eye did very well. It was a hot eye when we went in, and this is about 2 weeks post-operative. There was complete remission of the inflammation and has been doing well for the past 2 months now. Last indication, coming to the structural sequelae, as we can see, this is an epiretinal membrane secondary to vasculitis, a peripheral fibrovascular proliferation over the area of the vasculitis, along with, you can see some asteroid hyalosis here. So both things get treated with one thing. And after clearing out the vitreous, I think we can go to a higher magnification, lift out the
Simmer, just a second. Simmer, just a second. Mr. Raj, can we have that timer off, please? We're on time. I understand it's been timed to something. Thank you.
Yes, sir. Okay.
Thank you. Thank you. Simmer, please continue.
Thank you, sir, for that. And then, I'm sorry. So we just lift up on a higher magnification, lift the epiretinal membrane from the posterior pole. And again, so this is kind of a refractive surgery for retinal surgeons, a short surgery, trim it out to the periphery, and that completes the surgery, and again has a very gratifying outcome for these patients. Another patient with acute retinal necrosis in one eye, treated over 2 weeks with IV acyclovir and intravitreal ganciclovir, resolved well. Came back after about a month later with again a sudden decrease of vision. There was a retinal detachment in the healthy retina, supposedly healthy retina, that was left. And so again took him up for surgery, detached the hyaloid. You can see how the hyaloid came out as a sheet when we were just completing the core vitrectomy. And from over the area of the necrotic retina. And as soon as the hyaloid lifts up, you'll see a lot of sclerin coming along this whole temporal thing. You can see it right here. This indicates the subretinal fluid and the presence of the multiple breaks in this area. You can see this whole sieve-like retina over here. Almost 270 degrees of the peripheral retina was involved. And here you can see very clearly this thin necrotic sieve-like retina. I prefer not to cut this retina, but ultimately while removing all the membranes and everything, it was almost like a giant retinal tear over here. So again, triamcinolone to confirm the removal of the posterior hyaloid. There was none present, at least at the posterior pole. There was some pucker and the epiretinal membranes which were removed with the help of a intraocular forceps. And you can see at the edge of the healthy and the unhealthy retina, these membranes, PVR membranes that had formed and were keeping the brake pulled up. So they were all removed. And then practically this case was like a giant retinal tear, put in PFCL to flatten the posterior pole, and did a base shaving 360-degree. And after that, completed the PFCL fill, did laser at the edge of the healthy and the unhealthy retina 360-degree. And cryo to the flanges of the supposed giant retinal tear where they were anteriorly. And then a PFCL air exchange, and then the air was replaced with silicone oil subsequently. So again, the patient did well, had an attached retina post-operatively. So these were just some of the examples that I wanted to show. So in conclusion, vitrectomy has come up as an effective therapeutic option for both active uveitis as well as the sequelae of uveitis. The added diagnostic value of the sample obtained from the source is a boon, and advent of microincision vitreous surgery has made it safer and reduced the chances of post-operative complications. Thank you. Thank you once again to Dr. Mohit for having me.
Thanks, Sim. Great work. I think great. I'm going to omit all questions and then take, because your and my talk is similar, and we are just borderline on time. So I'm going to post those questions later on. I'm going to share my screen, and then we're going to come back to the final discussion at the end. Is my screen visible?
Yeah, sir.
Yeah. Okay. So I'm going to round this off. It's a tough act to follow after all these stalwarts that are there, and I'm going to talk about targeted biopsy in uveitis. So the biopsy in uveitis can be of various types. The overview is like this. I have quite a big, I'd say, presentation. I'll not cover all things. I'll need, the biopsy could be targeted extraocular, which is systemic. It could be local extraocular, which could be conjunctival. It could be aqueous or AC tap, vitreous biopsy, subretinal biopsy, chorioretinal, or it could be enucleation. And I'm not talking about your retinoblastomas and melanomas. If time permits, we might come to that. So we can click and go to some of these, but let's see, what time we have. So targeted extraocular biopsy. So typically, without too much of ado, if you suspect clinically tubercular or sarcoidosis, because both these entities require different treatments and long-term therapy, then since you can have abdominal issues as well, but the thing is that you get a good quality CT scan of the chest done, and then based on that, you can, for confirmatory diagnosis and not possible or probable, that's a mouthful, EBUS TBNA, which is endobronchial ultrasound guided transbronchial, either lung biopsy or lymph node aspiration. We had a publication on that in which we were able to have 30% patients who were confirmed to have either sarcoid or TB based on that. That is something that should be looked at. Of course, would not be done by you, but has to be requested by you so that your interventional pulmonologist can do it and help you out. Just another case. This is a 35-year-old male who presented with gradual painless decrease in vision both eyes for the past 2 months. 618, had a family history in that his father mysteriously had died of some illness in his 30s. She gave history of multiple episodes of dizziness and fatigue, had erectile dysfunction, bladder issues. When he came to us, he was on the wheelchair at sometimes, had multiple neurological issues with thickened sural nerves, and this is what he had on clinical exam. That's the slit examination of his cornea. You can see that those and this was present bilaterally, those point-like pinhead shaped regular millet seed, if I can use that term, deposits on the cornea. That is in the retrolental space, typical glass wool-like opacities, and those are the fundus montages of both the eyes. Cotton wool spot, microaneurysms, doesn't tell you much. The media is pretty good. There's not too much of vitreous inflammation, except if you don't look in the retrolental space. So had a retinal microangiopathy bilaterally. So what we did was we actually, since he had enlarged sural nerves, he was taken up for a sural nerve biopsy on our request by the surgeon colleagues. And this is the H&E stain on the left. It shows you the amorphous extracellular material, and the confirmatory Congo red highlighted by the green arrow, which confirmed presence of amyloid, and that was familial, hence his father had it. And this patient, because he came terminally, was ordered some systemic immunosuppression with hospice care. So this is the role of specific targeted systemic biopsy, which you might not be doing, but you would be requesting. Coming to a conjunctival biopsy, and this is again one case, a 64-year-old female who was diagnosed case of stage 0 CLL, which basically is that it's incidentally detected, but you can have blood counts as much as 1 lakh. But since you have no other organ involvement, they just watch you and don't treat you. So she was not being treated, and had some non-resolving redness, treated with oral topical steroid elsewhere, was referred to us. That's what she had. The anterior segment was fine. That's what she had, like a localized patch there. The ultrasound, showed a epibulbar extension posteriorly. That is the upper temporal scan, and you can see that the eye was quiet, but there was an epibulbar hypoechoic, extension there. And so this is what we did. We essentially, this is easy for anyone to do. That's the area which is fleshy, bulbous. So this is under peribulbar block. But to try and minimize bleeding and to have a cleaner plane of dissection, I did inject some, 1 into 10,000 ADR with lignocaine, which I'm doing right there, as you can see, in different areas, just as we would do akin to a conjunctival graft for a pterygium surgery. And then you would just, take your scissors, but to have a full thickness, conjunctival and tenons, you would want to do that biopsy, get this off. And after you cut that piece off, that's what you get. This patient eventually, and then you want to suture this off. That's not difficult to do. But what this patient actually had was that the histopathology showed presence of CD56 and CD3 positive lymphocytes in the substantia propria, which matched exactly with the peripheral blood immunohistochemistry and flow cytometry reports. Hence, she had epibulbar involvement. So she got bumped up from a stage 0 to a stage 3 CLL and was started on serum chemotherapy, and was eventually found to have that and that. So targeted extraocular biopsy, which helped with that. Aqueous biopsy is an AC tap. You can just take your taps and do. So this patient had a granuloma, as I was shown. And just to confirm, an AC tap was taken, had some KPs and inflammation in the anterior chamber as well, and that came out to be positive for IS6110 and RPOB genes, and hence confirmed TB, pan-uveitis with a choroidal granuloma. And this patient did rather well, and that's what that is. We'll quickly come to vitreous and subretinal biopsy. Simmer's covered some of that. I'm going to limit myself to jump vitreous and limit myself to subretinal and beyond. This is some of the data on diagnostic. Simmer also covered a couple of these. These are some of our articles on this, and if anyone's interested, they can do their reading. This is just endogenous end off. I'm just going to a video which was a patient had. So I'm actually going to skip this because Simmer talked about this. I'm going to just go on to subretinal biopsy. Simmer, how much? What's the exact time? I can't see the clock on my.
It's 12:10, sir. We have 15 minutes more.
We have 15 minutes more. Great. So I'll just take 5 more minutes and then I'll end. So this is a 62-year-old male who presented with bilateral gradual painless vision, very low acuity, had some vitreous cells, had these occluded veins, and had those yellow whitish deposits. Also had a cardiac history. That's the left eye, much more advanced features. Again, had some vitreous cells. A clinical diagnosis, that's what the angiogram showed, and the blown up picture shows you a typical leopard skin appearance on the angio, which is also seen much more in the left eye, which was the worst eye as far as the affliction of the disease was concerned. And this patient was with the clinical diagnosis of a lymphoma, was taken up for vitreous biopsy and subretinal biopsy of the lymphoma. So that's what we had. That's what the patient had. This is what we did, right? Under air. So the biopsy began under air infusion to get a undiluted vitreous sample. After that, we switched back to fluid, made an incision in the subretinal space with the cautery, and using passive you can see that soft tip using passive extrusion, just get those non-adherent lymphoma cells. We were able to get a big chunk of them by creating an opening. And then, as we would routinely do in RD surgery, do fluid air exchange, do laser, and we left this patient on SF6 gas. And this is what the patient had: CD20 positive, CD3 negative, diffuse large B-cell lymphoma. And this is sometime later. This patient eventually turned out and did pretty well. This is about 1 year later. This is a long time back patient. So that's what that's how you can do a subretinal biopsy. This is another example of a patient who had vitreous haze preoperative. We could see some lesions, but the vitreous haze precluded any kind of confident or clear fundus exam. Again, the biopsy was begun under diluted air infusion, as you can see. Sorry, undiluted biopsy was taken with the cut rate lowered to 800 cuts per minute and a manual aspiration being done. You can see air being infused, and us cutting the vitreous. You can get up to a 1.5, maybe 2 ml biopsy vitreous sample, and then you switch back to fluid, and then you can clear up whatever you want to do. After you clear the vitreous, that's what you had. You have some of these deposits inferiorly, and that's the lesion which was there, which was not visible preoperatively, temporal to the fovea. So for the subretinal biopsy, that's what we did. Just made a routine, retinotomy with your endocautery tip using the passive 25 gauge soft tip. Actually entered, we entered with that, and we were able to get out some of those, subretinal yellowish, what we thought were lymphoma cells. And this is passive, just attached to a 2 cc syringe. So just passively aspirating. And then we finished after we did with just doing laser, and I left this patient at SF6. What this patient actually had was, I'm actually going to skip that video. That's going to be something. So the vitreous fluid showed nothing. Now, why do subretinal biopsy? There's hardly scanty cells. The subretinal aspirate, you can see a lot of cells. The morphology is better, and they typically show you high nucleocytoplasmic ratio, large amount of nucleoli, and CD20 positive. So just a vitreous biopsy in this patient would have been negative. However, subretinal biopsy saved the day. We're just going to end with one video. I'm not going to show. I had two more quickly just to show chorioretinal biopsy and the limited indication where that might be needed. This is thanks to, this is because of courtesy Dr. Raman. This was actually taken from me. So the known case of toxoplasma was being treated, did fairly well. However, a week later had extremely poor vision and got down. The vision went down to hand motions because he had a bleed. So the regular biopsy was done, and you can see how thick the hyaloid is, as you will see right now. So that is not the retina. That is the thick, organized sheet of posterior hyaloid, which is just fibrosed over like a frozen lake. And the retina and the blood is, all of that is below it, as you'll see. So after clearing, you can see the retinal blood vessels, and you will be able to see those lesions clearly in a bit. So that's what. So all of those are the retinitis lesions. With some vasculitis in the periphery and multifocal retinitis lesions. This patient had received an Ozurdex injection elsewhere and was referred to us, hence the multifocality. We wanted to take a chorioretinal biopsy at this point in time because we want to know what's happening. Mixed infections are common, and although this patient responded somewhat to anti-toxotherapy, he had this precipitous loss in vision, which was atypical, for someone to have that amount of bleed. So a safe site was chosen superiorly, akin to what you would do to exteriorize a large foreign body. A separate sclerotomy was made with the MVR, and you had your old school scissors that you would use in maybe the 20 gauge era. And they were used to actually delimit and cut out a portion of the retina and a full thickness of the choroid involving healthy and the diseased retina after laser demarcating it. Yes, there was some bleeding, but that can be controlled by jacking the myopia up. You can see at the top left corner of the screen. And after much manipulation, the piece was actually brought out, as can be seen there. There was another piece which was subsequently brought out, and this was sent to the histopathologist in formalin. And the patient was that's what was done. And after a good laser, we closed the patient on oil. So this is just a how a chorioretinal biopsy works. You can have other things in which your chorioretinal biopsy might be needed. A diagnostic enucleation, I'm just going to skip that for want of time. A diagnostic enucleation might be needed in atypical cases of sympathetic ophthalmia, like this one-eyed lady in which it looked nothing like sympathetic ophthalmia. The angio didn't look like it. We were suspecting a masquerade or AN. However, the blind eye was, enucleated, and this showed a rare atypical aggressive form of sympathetic ophthalmia, which is sympathetic retinitis, in which the inflammatory response tends to be directed towards the retina and not the choroid, and hence the choroid doesn't get thickened. The patient doesn't present with exudative RDs and KPs, but instead presents with massive outer retinal loss and rapid onset of fibrosis. However, we were able to manage this patient with, because of timely diagnosis and more than aggressive immunosuppressive therapy than you would give in a conventional sympathetic ophthalmia patient. We were able to manage this patient with IVMP, rituximab, and azathioprine, and this patient continues to do well. So with that, I'd like to actually draw a close. I think we're just bordering at the at the end of time, and I'm going to stop sharing. Just open the house for anyone or any comments from Raman sir, from Simar on regarding any of the vitreous or the biopsy techniques, sir.
Mohit and Simar, it was.
So you're muted, sir. Raman sir, you're muted, sir.
We can hear Raman. We can hear you, sir.
Yeah. So it was excellent.
So Raman sir, you're still muted, sir. I can't hear.
No, Raman. We can hear Raman.
Sorry,
sir, so
my bad. Apologies.
Yeah.
Those were excellent talks. I mean, Simar has rightly said, if you are planning vitrectomy in uveitic eye, you do not wait for eyes to be quietened up. You take them as fast as possible. This is what we learned from the cysticercosis there. If you have a cysticercosis there, if you have a toxocara there, we used to go in and we never used to, wait for the eye to quieten down, as happens in cataract surgery and the glaucoma surgery. And those were the excellent examples you presented. But again, early surgery, not waiting the eye to be quietened, is very important. And in the MIBS era, the surgery is very safe. And above all, I think you require a team of cytologists, pathologists, microbiologists to be with you to take care of the samples which Mohit are going to provide. So I think it's a beautiful surgery and examples you've given.
Thank you, sir.
Thank you, sir.
I didn't actually, sir.
I want to comment. Actually, I am so impressed with the surgical procedure which is carried out by Dr. Mohit and also Dr. Simar. No doubt, I think Raman is a class apart for complicated cases, but you people are also not doing less complicated cases. That is what is my comment for both of you.
Thank you, sir.
Thank you very much, sir.
Thank you. Simar, I'm going to just keep this discussion going for 5 more minutes. And can I request you to log out and log into, there is a session that Simar and I need to be at in the YO pavilion. Simar, can I request you to...
I'm going over there on a separate laptop.
You are going on a separate laptop. Great. So you'll be there. So I have just two quick questions to you again. So Raman sir, in all of these patients, whether a therapeutic or a diagnostic vitrectomy is being done, even if the patient is very young, let's say 1 year, 2 years, would you recommend a full hyaloid removal? Would you recommend going the whole hog and getting the inducing a PVD?
I think inducing PVD in these eyes is very difficult, but if given a chance, I would like to do vitrectomy, complete vitrectomy in these patients. But you have to be very, very safe in these eyes, that you do not create iatrogenic breaks. So as much as possible, you should try to remove in these eyes, because in eyes with inflammation, if you are doing the active aspiration to remove the hyaloid, there is a different story. So eye where the retinitis is there, eye where the retinitis is not there, they are two different eyes. Where the retinitis part is not there, you can easily remove the hyaloid. But if the retinitis is there, and you have to go very slow, and maybe if it permits that hyaloid is coming out easily, and till the edge of the retinitis, you can move it, but you should not go overboard to remove it. But again, as the things are improving, as our machines are improving, people are going more and more for hyaloid removal.
Absolutely. Agreed, sir. And just one more question, sir, before that, I'll just like to ask. So, Mr. Raj, we have 2 minutes, or would you want us to wind up right now?
Yes, sir. We have 2 minutes. You can go
Great,
with.
great. Because we're on time. I
Yeah.
mean, we planned it that way. So
Yeah.
we will give the podium to you in 2 minutes so that the
Sure,
next
sir.
session does not suffer. Thank you, Mr. Raj.
Sure, sir. Thank you.
Raman, sir, a quick question to you. So, Simar, no questions to you and me because of lack of time. We're just going to ask Raman, sir.
Absolutely, sir.
So would you recommend for these eyes, even if the eye is inflamed, we established that doing vitrectomy even in an inflamed eye is not a no-no. In fact, it might be recommended given that we don't know what's happening. But if the media is not great because of cataract issues, would you recommend a combined surgery also, given that the inflammation is not controlled? So a combined cataract vitrectomy also, or would you still just say that get the vitreous sample out and get the cataract surgery done later?
I think again, the point here is how much comfortable you are doing a vitrectomy there. And if I give you an example of an endogenous endophthalmitis in an eye, in a patient.
Sir, if I can say non-infective, sir. So if it's a frank endophthalmitis, that's a separate issue, sir. But if it's a non-infective.
If you're talking about the uveitic eyes, I would like to keep the cataract for a later stage as much as possible.
And not try to combine the two, sir.
Yeah, not try to combine this.
And just one question to Pandav, sir. Sir, if you're there, sir, what would be your approach to managing neovascular glaucoma and uveitic eyes, sir? Since it's different from our regular diabetic or CRVO ones, because here in younger patients, and what would be your just quick algorithm for neovascular glaucoma secondary to uveitis?
Basic principle would remain the same, that you treat the underlying pathology first. So if the uveitis which is active, that needs to be treated, and if there's a vasculitis, that needs to be treated, and if there are any vascular occlusions happen because of that, that needs to be treated either with steroid immunosuppression or with lasers. So you need to control the neovascular process before you do anything anteriorly. Of course, in the acute stage, you have to manage the IOP by whatever means you can. But before you do a surgery, I think your neovascular should be.
When you want to operate such cases.
Sorry. Did someone?
Yeah. So your neovascular process should be reasonably controlled, and then you can actually do the medical therapy or put a tube, because neovascular glaucoma, by and large, if it's it doesn't do well with the routine trabeculectomy. So the tube is an option. So if the inflammation is well controlled, anterior segment is preserved, one can still think about doing a trabeculectomy, but by and large they would end up with a tube.
Absolutely, sir. I agree. Thank you, sir. Thank you. With that, I would because we have just been on time. It's 12:25, and I think that was the time allotted to us. So I would like to thank Professor Jagatram sir, Pandav sir, Raman sir, and Simar. Thank you for agreeing to be a part.
Thank you, sir.
And needless to say, bringing a lot to the table. And if I can just finish by making one comment, the number of participants showing here might not be great, but I think that is because of two reasons. A, it's a working day, it's in the middle of the day, and in today's day and age of COVID, with people getting used to listening to webinars and these talks in their free time, I'm pretty sure once they are up on the AIOS kind of website or their collection of talks, I think people who deal with any kind of uveitic patients would gain a lot from listening to various aspects of uveitic complication management that we have touched here. So
I think the participants showing here are the faculty who are waiting for the next session. Sir.
Yeah, of course.
The actual audience is on the separate platform.
Yeah, right, sir.
I don't know. My bad. My bad. Apologize, but because I saw Madhuri there, so that was that. But thank you for correcting me, Simar. Thank you, and thank you everyone for participating, and thank you, sirs and Simar.
That is a wonderfully conducted, I think, instruction course.
Thank you, sir. Thank you, sir.
Okay, thank you, Dr. Mohit.
Thank you, sir. Thank you, Mr. Raj.
Thank you, sir. Thank you all, doctors. It was a wonderful